So I do EHR and genomic kind of research here, and I'm in neurology. I also see dementia and movement disorder patients. So I'll talk about our work mostly in dementia. So just one quick slide. So dementia has many, is devastating for many people. There are problems with memory, language, visual spatial problems, and executive function. It has a high cost. There's about 11% of people over 65 who have this diagnosis. If you're over 80, it's about 30%. And there's no medication that can reverse or stop. There's some new medications out there called lecanemab and donanemab that have been showed, that's been approved in like the last year to try to decrease has been showed to slow some progression. So like many other diseases, some of the problems is how do we identify who is going to progress to Alzheimer's disease and what maybe potential subtypes they may have. And a lot of that work, as in other studies as well, has been done in academic centers like ours, predominantly from European or non-Hispanic white population. So our lab is interested in this precision medicine equity, where we're trying to use real world data and look at understudied populations. So I'll just talk about one aspect that we're working on and looking at disease trajectories in Alzheimer's disease. So one of the things that we thought about was initially is what unique perspectives can EHRs provide in dementia research. And one, we do have time. So for example, we know when diagnoses were made in relation to other ones. So for example, hypertension to gout to hearing loss, then leading to Alzheimer's disease. This is AD here. And when we think about traditional versus time-dependent risk factors, we can think about, well, maybe A and B are known to lead to Alzheimer's disease, but B and C are not. But if we think about maybe the temporal association between B and C, maybe if B is before C, then that does actually have some risk for Alzheimer's, but not C to B. And one question was, how do we quantitatively compare disease trajectories? So we had to kind of take a step back and think about, well, how do we calculate the distance between diseases in the EHR? And this is work that we did with Luz, actually, and a grad student in my lab. But I'll talk briefly about this. As you know, in the EHR, there are these ICD codes, and within the ICD codes, there's multiple chapters, 12 chapters, and in chapter 6, there's Alzheimer's disease here, but within each chapter, there's subchapters and subcategories. So essentially, we think about it as a tree structure. So when we first thought about this was, if we wanted to compare distances between diseases, the tree structure maybe doesn't really make sense to do that, right? Like G30 versus G31, maybe you give a distance of 1. What do you do across chapters? So it can be a little challenging. So we thought about, and not only us, but others have thought about using these knowledge graphs to help identify distances between diseases. And one example here is SNOMED CT, and SNOMED CT is a knowledge graph with relationships between, let's say, Alzheimer's, and we know it is a associated morphology of this degenerative abnormality. So the idea when we do this knowledge graph embedding is that two diseases that are close together in this knowledge graph are close together in the embedding space, versus something farther away like breast cancer in the knowledge graph should be farther away also in this embedding space. So there was a model that had already been developed called Rotate-E to take SNOMED terms into an embedding space. And we wanted to look at ICD codes. So we essentially mapped ICD codes to SNOMED and did this embedding, but then we also compared to the distance if we looked at ICD tree structure. We actually calculated comorbidity distance between two different diseases and looked at genetic correlation-based distances as well. So the highlights from doing that was that, for example, if we look at the embedding distance in the ICD structure, if you just calculate some naive tree structure distance, there's all these diseases look the same kind of in the top right corner. But if we look at these SNOMED CT embeddings, this is the cancer chapter. So actually there's some kind of like sub-clustering here that you can identify. And these are basically subtypes of organs for cancer, right? Like breast, I think breast and ovarian were together and things like that. So that helps you identify some more granularity compared to the ICD structure. And then we also did some correlation analysis between if we calculated the the genetic distance between two diseases that was correlated with the embedding distance, and then this is a little squash, but also if we looked at the comorbidity distance, this was mildly correlated as well with the embedding distance. Okay, so that was the 2-minute summary of over a year long work. But so in the end, we identified that the this SNOMED embedding can capture the phenotypic, clinical, and molecular structures kind of at a finer granularity than some other distances that were available at the time. So here we could maybe use our ability, use this method to identify disease trajectories and maybe subtypes and do some clustering. Okay. So what is a disease? These are disease trajectories, and there's been prior work done on this. So for example, in Jensen in 2014, they basically identify pairs of diseases, sequential patterns of diseases like A to B and B to C. And then what they do is they combine them into longer strings. This next work by Giannullo, they take trajectories if there's been matches from two patients, right? So like A and A and B and C and C match, so they extract those and they look at this trajectory A, B, C. There are some limitations. One is just because you combine disease pairs into a longer disease trajectory, it doesn't mean that trajectory, the longer one, actually exists in real life. The other one is that these kind of look at this method looked at exact matching. So there's not non-exact matches really are not considered. So I'll give a quick methods overview and then kind of go into the study design. But our plan was we had to do a decent amount of trajectory cleaning that I'll talk about. We do the embedding from ICD codes into this embedding space. Then we can actually compare disease trajectories using dynamic time warping. We cluster those distances, and then now we have clusters, and then within each cluster, we can create this like big map of all the disease trajectories within each cluster, but it's a little challenging to interpret sometimes. So we do this. There's many strategies out there for this is called network backbone extraction. We've tried a couple. I'm going to show results for this one called modularity vitality. Okay, so this is our study design. We'll start with one. So first, we initially was doing this on UCLA only, but there actually is a UC data warehouse that includes like 7 different sites, like UCLA, UC San Francisco, that's accessible. We actually used that data, and then we excluded some patients based on age criteria. And then we have our final eligible samples, and we could take AD cases. So there's 24,000 AD cases. That's just by one AD-ICD code, and we can talk more about that. And then there are those without it. There's some other restrictions we're doing, and then we have this 288 that are not AD. And how we use those, we really just do some one-to-one propensity score matching, and then we find these temporal associations from ICD codes. I'll get more into that. And then we do this trajectory identification, subclustering, and then we do some evaluation there. So I'll go through a little bit more detail about some of these steps. So the trajectory cleaning, there was issues initially. If you just take every single sequential pattern, there's a lot of patterns, it's very long, and then sometimes they were less interpretable. So what we decided to start with was we essentially used a fine-grained proportional hazard model. So this accounts for a competing risk of death, and this is used a lot in the AD literature research. It's essentially like survival analysis, but accounting for a competing risk of death. And we find all the pairs that are associated with AD sequentially. And then from those pairs, like at the T-1 position, then we find all the pairs that were associated with that one. So then that gives you 32,000 positive associations between all ICD codes. And this is by like the 3-digit ICD codes. So here's examples of the AD diagnoses that are temporally associated. So there's unspecified dementia, there's bipolar, there's depressive episodes. And then we can actually build these trajectories from patients, because now we have known positive. We actually take the positive, not the negative ones, because that made it a little difficult to interpret as well. Then you could kind of, from a patient's very long disease trajectory, we take only the pairs that we already know are positive risk factors based on this prior analysis. So once we do that, that helps clean up a lot of trajectories, helps improve interpretability. And then there's the last step is some trajectories can be really long. So if we take the ones, we remove the ones that are over 10 essentially, and that's only like less than 1% of patients. Okay.
Can I ask?
Yeah.
For patients, do you have to match on sex?
Yeah, we did for this part. Yeah, we did. There's two parts. Just for the AD ones, we took AD and propensity match sex age controls. So that's how we got the AD risk factors. But actually, we decided partially for computational reasons is for the other risk factors, we only looked within the AD cohort of like 24,000 actually. Yes. And part of the reason why we did that was also because we were interested in these AD trajectories, but then we also wanted to compare to controls later on. So it kind of was, it's not really a holdout set, but it's a little separate, yeah. Okay, so now we have these clean trajectories of multiple people, and then we can calculate the distance between multiple trajectories, and they may be different lengths. So we use something that's probably well known as dynamic time warping. So the idea is to find the optimal alignment path between two disease trajectories. So instead of like Euclidean matching directly at time 1 to time 1, you could kind of match at different times, and we have a distance that we talked about before between ICD codes. The one caveat is that you can also we have to end in Alzheimer's disease, so that's the last step, but the beginning doesn't always have to match. So it's called like open begin matching, not open begin open. But so we let the first time point doesn't have to match, but the last one does. And this is one of many of these network backbone extraction methods. So the classic example is like taking a flight path and trying to simplify, looking at the network hubs. And this method basically looks at the density of links inside these communities, and one by one tries to take away a node or edge and see how these network modality scores change. So it's one of many methods. It's better probably than just having like a direct cutoff between like a score of a weight, right? Because there are some areas of the network where if you use a 0.5 cutoff, let's say, there are some that are more dense versus less dense, and you wouldn't want to just have one cutoff for the whole network. So in the end, we end up, the idea is essentially to have you have a complicated network, and then you have a backbone extracted kind of simplified network. Okay. So we talked about using the UCLA Health Data Warehouse. There's just some more details about the demographics, the age cutoffs. We use initially some record length diagnoses, like the total number of diagnoses and encounters you have to have as criteria. And then the controls specifically for the fine grain analysis, we wanted controls that had been in the EHR longer, right, to make sure they potentially didn't have Alzheimer's disease. So we increased the record length and the number of diagnoses. This is after propensity score matching, but it kind of gives you an idea of the age of the cohort. So the average age is about 81. There's more females, 62%. That's expected and known. Females live longer. There's the breakdown of race and ethnicity. It's about 65% white, and then 12% Asian, and about 6% Black, and 11% Hispanic. So that's similar across these. This is age matched. And then these are the different sites. I think we're not allowed to like write which site is which site. So we have 1, 2, 3. Okay. So this is what happens if you take all the Alzheimer's disease patients, and the way we actually make these edges is just the proportion of patients that have a transition from, let's say, I67 to G30. So that's how the edges are weighted. And if we look at all these, this is kind of difficult to read, partially because there's a lot of diagnoses, and it's a circle. But there's many mental health diagnoses. But we wanted to gain some insight. Maybe if we do some clustering, maybe this could be helpful to identify some subtypes. So I'll show the clusters, but first wanted to show the demographics of them. And there's essentially kind of four clusters that we identified. So one is this depression cluster or mental health cluster. There's an encephalopathy cluster, which is like confusion, particularly it can happen in the hospital. There's mild cognitive impairment. This is a diagnosis that can happen before dementias. And then there's this vascular category. So we know that cardiovascular disease is a risk factor for dementias. So all in all, these did make sense. I guess encephalopathy was a little interesting, but there's some differences in genders. There's a little more females in the depression cluster, a little more Hispanic in that cluster as well. The MCI has more non-Hispanic whites, if you actually look, there's some differences in the total number of diagnoses patients have. So in the encephalopathy one, there's only 20, but in vascular, they have the most. They have 65 total diagnoses. Let's see. And I'll get into a little bit of that later. Okay, so I think it's helpful just to see a picture. So this is our depression cluster. So by the way, G30 down here is Alzheimer's disease. And we've tried to look at this in multiple ways. So one is we started describing these based on the central node, and one of those nodes is here is depression. And we looked at the nodes leading into depression up here. So there's anxiety disorder and hypertension as well. And then here we took the top 5 trajectories from this cluster. So for example, anxiety to depression, type 2 diabetes to depression to Alzheimer's. So we have these different patterns that we saw in this depression cluster. And some of I think it's interesting actually to go kind of cross chapter. So for example, you can look at longer trajectories, right? So looking at lipid disorders leading to depression, then unspecified dementia, then this G30 Alzheimer's disease. So we've been looking at these longer trajectories, and similarly, we can look at the next one is encephalopathy. So this one was a little interesting because if you just look at this G93 code, it doesn't really make sense because it just says other disorders of the brain. But looking specifically at what the percentage of patients in this cluster that had some of these subtypes, encephalopathy was the main one. And you see the progression from this G93. There's also diabetes and hypertension, and there's urinary symptom problems too. So I thought this was interesting because many people who have encephalopathy or confusion, it happens because of, let's say, infection, or they have kidney issues, or they have so many metabolic causes that lead you to have encephalopathy can also lead to Alzheimer's and dementia. So here it's highlighted again here at this kidney failure. This is basically encephalopathy and Alzheimer's disease. All right. This third one is this mild cognitive impairment cluster. Again, this is a G31 ICD code, but if you look, 70% of them have this mild cognitive impairment. And we see interesting diagnoses here. So there's so this is a TIA, like a stroke, small stroke leading to MCI and then Alzheimer's disease. I think that does happen clinically. And then we find these other ones like disorders of the lacrimal system. I'm pretty sure that's tearing, and then menopause as well as a precursor to MCI. All right. And the last one is this vascular disease one. So this is cerebral vascular disease. So we know that this can also be a risk factor for future dementia. And we see many of these are actually like musculoskeletal that are precursors to cerebral vascular disease, which may not be causal, but may be related to, let's say the age or something like that. Okay. Let's see. All right. And this kind of pathway combines kind of different clusters we've seen before, like kidney failure, encephalopathy, and cerebral vascular disease. All right, so what can we do with these clusters? We were thinking about different ways to evaluate them besides what we've shown, and one thing we do have time information, right? So if we look at the central node, we can look at the time to Alzheimer's disease. And what we see is that this one, this G31, and this G93 is the encephalopathy one. This actually has the shortest time. Once you have encephalopathy, you get the shortest time to have Alzheimer's disease compared to the other clusters. And we can also look at this in terms of two things: time to Alzheimer's disease and AD, and time from Alzheimer's disease to death. And I thought this was interesting as well. If you look at, this kind of shows again, if you look at this encephalopathy one, once you get diagnosed with, once you're in this cluster, we looked at the time from the initial ICD codes encounter until the time you got Alzheimer's disease. And many of these in the encephalopathy had a short time to AD diagnosis, versus this vascular dementia, they have a longer time to AD diagnosis. And there could be, yeah. And then also this is a AD time to death. It's hard to tell, but this encephalopathy one also has a shorter time to death from Alzheimer's disease as well. Okay, and I think last couple things is that one question I kept having was, these are great, these are disease trajectories in AD we identified, but how does it compare to controls, and what is, like, does this add, like, what's the new information this adds? So we included, the cohort included AD and controls. They were never diagnosed with Alzheimer's, or we had these fee code exclusion criteria. And from each of these clusters, we tested a few these risk trajectories, right? And what we did was we compared that risk similarly in a fine gray model. We compared that to all the people who did not have that risk trajectory. And we can identify this relative risk is elevated for essentially all of these, particularly more so in this MCI, it's about in the 2.3 category. And we also compared this to if you just had one of the risk factors, like the first one, right? So if you have both of them together, or if you just had the first one, what does that mean? And both of them together predominantly does increase the risk of having Alzheimer's disease. So it's not just it's the pattern that matters. All right. And the last thing we wanted to try was to do some causal structural learning. We use this greedy equivalent search algorithm. This is a score-based method, and uses, so we greedily search through this Markov equivalent classes of these causal networks. We do in a one-to-one match case control that we showed before, and then we do cross-fold. We did some 10-fold cross-validation, so we split the data set multiple times and just wanted to make sure the edges that were causal in one fold also were causal in the other fold. Interestingly, about 26% of the edges that we had identified that I call like temporal associations were also considered causal based on this causal structural learning. And some of those include this vascular dementia that I talked about, and depression is down here as well, the other cluster as well. So in conclusion, we developed and applied these distance measures and tried to compare disease trajectories. We used this fine-grade hazard model to account for loss of follow-up and competing risks of death. We identified these disease trajectories and tried to compare them to controls as well. So, in the future, we want to incorporate time between diagnoses more to help do these subclusters. And we had wanted to look at genetic risks. The technical issue is that the UC Data Warehouse, they randomly change the IDs every month, so it's hard to match back to UCLA, where we have the genetic data. So thanks so much, and this work was all done by Joy Fu here, and thankful for all the support.